All right, good morning. Welcome to the Insurance and Pharmaceuticals Subcommittee, the Health and Government Operations Committee. I'd ask that everyone put their audio on mute during the meeting. I'm hearing some folks. All right, we have a number of bills to discuss this morning. There's been a lot of work on these bills. I'm hoping that this discussion on the bills that we're going to be talking about today will lead us to a good disposition of them. We are holding House Bill 381 and House Bill 665. So if you are here for either one of those bills, you're welcome to stay and watch, but we won't be discussing those bills today. We are going to be starting with House Bill 936, Health Insurance Cancellation and Non-Renewal of Coverage, and that is Delegate Shetty's bill. Lisa, would you tell us what it does?
This bill requires a carrier to send a written notice of cancellation or non-renewal of coverage of a small employer plan by electronic means. The notice must include information on additional health benefit coverage options, including the Consolidated Omnibus Budget Reconciliation Act and the Maryland Health Benefit Exchange. There are amendments that were distributed. The amendments distributed strike language requiring notice by certified mail, require the notice to include information on the options of Medicaid, and require the Maryland Insurance Administration to adopt regulations. The amendment also changes the effective date to January 1st, 2026. So it's my understanding that since I sent out those amendments, that there has been an agreement to change those amendments and to take out the provisions about Medicaid and requiring regulations to be adopted. So the amendments that are being considered now would strike the language requiring notice by certified mail and also change the effective date.
Okay, Delegate Shetty, welcome to the subcommittee. And would you like to tell us about your bill?
Yes, ma'am. Thank you so much, Madam Chair. Good afternoon, good morning, almost afternoon, colleagues. It's good to see everyone here. This is a bill that you all heard, I believe, last week that was related to one of my former students at University of Maryland whose family lost coverage because they were insured through her father's plan. And then once he passed away very suddenly, they didn't receive notice of termination until many months after. And at that point, they had passed the qualifying enrollment period to be able to enroll in plans elsewhere, even though they had had options elsewhere had they known of the termination of coverage. So this bill just cleans that section up that would enable
Just let Delegate Bagner's
insurers
office
provide
know.
meaningful notice within the time frame so that a person who is affected can then enroll in a plan, ideally like on the exchange or via COBRA or whatever works best for their family.
Okay, thank you very much. Delegate, are you comfortable with the two amendments that we're kind of talking about now? One is striking certified mail and the changing of the date.
Yes, ma'am.
Okay. Lisa, is there someone we need to speak to or speak with about the amendments we're striking?
You could speak to the Insurance Administration, or Matt has his hand raised. I'm not sure.
Okay. All right, then Matt Celentano, you want to speak to those two that we're not talking about?
Madam Chair, thank you for the opportunity. I just wanted to say I think the carriers are fine with the amendments, and we want to thank Delegate Shetty so much for collaborating with us, and we are comfortable with the bill moving forward. Thank you.
Okay. Jamie Sexton.
Just wanted to chime in and echo the sentiment. We really appreciate Delegate Shetty working with us on this and her flexibility to get this into a place that the MIA was comfortable with. So just wanted to really applaud her collaboration on this and her leadership on this effort.
Thank you, Jamie. Is there anyone else who wants to speak to the amendments now? Seeing no one raise their hands, can I get a motion on the amendments?
Moved.
Moved.
And
Second.
We've got a motion and a second on the amendments. Any discussion on the amendments? Jamie, I'm assuming your hand is just a residual hand.
It is. I apologize. I will lower it now.
That's okay. Those in favor of the amendments, please say aye and raise your hands.
Aye.
Will there be any opposition to the amendments? Seeing none, the amendments pass unanimously. Can I get a motion on the bill as amended?
Move the bill. Second.
And a motion and a second on the bill as amended. Any discussion on the bill as amended? Seeing none, those in favor of the bill as amended, please say aye, raise your hands. Is there any opposition to the bill as amended? Delegate Taveras, are you voting with or?
I'm voting with,
You're
ma'am.
voting with. Okay, then the bill as amended passes unanimously. Thank you, Delegate Chetty, for joining us this morning. All right, we are going to move to House Bill 939, which is Maryland Commission for Women, Maryland Collaborative to Advance Implementation of Over-the-Counter Birth Control. And Lisa, want to talk to us about that bill?
So the bill requires the Maryland Commission for Women to establish the Maryland Collaborative to Advance Implementation of Coverage of Over-the-Counter Birth Control. There is an amendment that was distributed that would authorize the collaborative to consult with professional associations with specified expertise.
Thank you. I know that the executive director of the Women's Commission on Women is here. There
am.
she is.
Thank you, Madam Chair. So lovely to be back.
No, it's lovely to have you back. So thank you. Would you like to speak to this bill?
Sure, very briefly, because we just had the hearing. I'm very excited about this. The chair put this bill in, and it's a way to really support the work that your committee has done for many, many years in terms of birth control access. And I think it's a really great use of the resources that the Commission for Women has. Camille, who's on my staff, who also used to be with Delegate Shetty, if she's on the call, and interned with Chair Pena-Melnick, is going to be working on this project with the Commission for Women to really hi Camille, thanks for turning your camera on. So we're really excited to be able to move forward with this and hopefully have a productive collaborative that has meaningful recommendations to improve access to over-the-counter birth control, both in an interim report and a final report. The amendment that you have before you addresses the letters. As you know, whenever we do anything like this, there's a lot of piling on and people want to be involved, of course, because I was trained by the best. We will consult with everybody and anybody, as is the HGO way, to make sure that we get the best recommendations. And the only other thing I will add is that the stakeholders on this collaborative include multiple different state agencies. So, our goal is to use their expertise and their recommendations and just do a lot of the, staffing work to take that burden off of them. But obviously they're the policy leads from the state government perspective.
Okay. Is there anyone else who would like to speak to the bill in general? Seeing no hands, do I have a motion on the amendment to consult with relative entities?
So moved.
And do I have a second?
Second.
It's been moved and seconded. Any discussion on the amendments? Seeing none, those in favor of the amendment say aye and raise your hand.
Aye. Move as amended.
Okay, got a motion on the bill as amended. Do I have a second?
Second.
Moved and seconded. Any discussion on the bill as amended? Seeing none, those in favor of the bill as amended, please say aye, raise your hands. Will there be any opposition to the bill as amended? And I see it. Delegate Morgan, is that opposition? Okay, so Delegate Morgan, Delegate Kipke. Hold on, and I've got to, there we go. Okay, so the bill as amended passes. Thank you very much, Ariana, for joining us today. You're welcome.
Thank you so much for the work you do. I will peace out, but keep going.
Okay, thanks. So we're going to go back to House Bill 666, Maryland Medical Assistance Program and Health Insurance, required coverage for calcium score testing. Lisa, tell us about the bill.
This bill requires carriers as well as Medicaid to cover calcium score testing for individuals in accordance with certain standards. There are amendments that were distributed that specify that the coverage is required in accordance with the most recent guidelines of the American College of Cardiology.
Okay. Delegate Woods, would you like to speak to your bill?
Yes, we are in, has a Senate cross file, and we are in agreement and receptive to the recommended amendments and most appreciative.
Okay, thank you. Delegate Kipke.
No questions here.
Oh, okay. Delegate Kaiser.
Thank you, Madam Chair. I just want to understand, I just took a look at the amendments. Are they effectively similar to your desire, Delegate Woods, to what, 3 out of 4 risk factors? Is that a similar standard?
Yes, Delegate Kaiser, they are definitely a similar standard. There were some other standards that were also added. And again, based on what that physician is saying, that specialist is saying, and we are certainly appreciative and receptive of those additional standards that may be a reason for having the calcium score testing. Thank you.
Thank you.
Okay. Matt Celentano, were your questions? Oh, there's your hand again. Okay. Matt?
Oops, sorry to turn off my camera. Madam Chair, I just wanted to say thank you to Delegate Woods for letting us work through our concerns. We're mostly based on the safety portion of the program, and then it went through another iteration, and we got to this final one where there's a set of standards that the carriers are comfortable with. So thank you so much, Delegate Woods, and we are good to go on this one as well. Thank you.
Oh, thank you, Matt. Dr. Moran from the Maryland Health Department.
Yes, Chair Collison, and want to offer up the opportunity potential. We have our Chief Medical Officer on the line who is looking at this and wanted to weigh in here. And Dr. Lindsay, do you want to address the potential opportunity to broaden just a bit? I don't know if we'll need further conversation on that, but Dr. Lindsay, do you want to tee that up?
Yeah, we just as we sometimes hesitate to name a specific clinical guideline as those can change, and when they get legislated, if there are changes in terms of what is the industry standard, then that requires going back to legislation. More than likely, the American College of Cardiology will be the prevailing body, but there are times where sometimes the United States Preventive Service Task Force will take a look at the large body of data and make varying recommendations from the specialty group. So we did have a recommendation to broaden the language to current clinical guidelines, and that would be accepted as carriers could then follow those guidelines of American College of Cardiology.
Okay, I'm going to go to Matt Celentano. So let me make sure I understand. So instead of saying in accordance with the most recent guidelines of the American College of Cardiology, it would be in accordance with the most recent guidelines.
Current clinical guidelines a little broader.
So, Madam Chair, I think I'm confused. So what's the amendment in the insurance article or in health general?
I'm in the pharmaceutical.
We are just cautioning on specifying a specific guideline in the event those guidelines shift or change or are no longer the industry standard.
I think that's why we were comfortable with it being the most recent guidelines. So as it's updated, that carriers would, and I think that was an MIA suggestion for it to be the most recent guidelines. We had actually suggested the American College of Cardiology in general, and the MIA had added most recent. So I thought we would be keeping up with the times on that front. And also the reference to the U.S. Preventive Services Task Force, carriers already have to cover all of those services anyway. So to us, I think
the reference was that there are some times where the USPTS will come back and override a specialty group's guidelines based on their larger bodies of evidence. So that's happened in the instance of prostate cancer or PSA screening, where you see there's varying between what urology would recommend and what's recommended by the Preventive Service Task Force. So it's not just to note that if we do specify that, there might be a point in time where we have to come back and reevaluate if that guidance changes.
I guess my question would be then for the MIA folks. So if the U.S. Preventive Task Force Services comes in that something is not recommended by the American College of Cardiology, carriers are going to have to pay for it anyway, correct? We're already going to have to cover it. That federal guideline would trump the state law, correct? MIA friends?
I believe
Jamie?
that is correct, Matt.
Yeah.
Can I just specify that in my experience that what's often happens is that the specialty groups actually ask for more coverage than what preventive service task force would ask for. That's been what I've seen in my clinical practice.
So wouldn't this cover that then?
No, then there would the USPTSF would be the prevailing guideline, and then there might be some variances again with the specialty groups. All that to say is that it should be current clinical guidelines. The current clinical standard is ACC. There might be a point in time though where that shifts.
Okay, I'm going to go to Dana Kaufman. She's been waiting here.
No, and just on behalf of MedChi, I think we are comfortable with the recent guidelines of the American College of Cardiology. I don't know if we would be comfortable with just an open-ended, the recent guidelines, because it then is, it's unclear about which guidelines would be used. I just think it's too open-ended. There are other instances in the code where we do point to the leading specialty. So I do not think, and that to my knowledge has never been any issues. So I don't think that this is unprecedented. So I think we would feel more comfortable with staying with the current amendment language. And if there is a problem that comes up, we'll have to deal with it. But I think that this one is better than just keeping it open-ended to recent guidelines.
Jamie, you want to speak to that?
Yeah, I would want to touch base internally with our team. I worry about enforceability without specifying what guidelines we're talking about. And I could be off base, but I would want to check in with our team that would be enforcing this provision to ensure that they would have what they need if we took out what guidelines we're referencing. I do worry about the open-endedness there. But if it's possible to have a little time to discuss that with our team, that would be wonderful.
So with the indulgence of the committee, I'd like to hold this bill and we will take it up at the next meeting. Okay, thank you all for the discussion. And hopefully we'll get that resolved quickly. We're going now to House Bill 820, Health Insurance Utilization Review, Use of Artificial Intelligence. Lisa.
This bill requires carriers, pharmacy benefit managers, and private review agents that use artificial intelligence algorithms or other software tools for utilization review to ensure that such tools are used in a specified manner. The bill also alters the information a carrier must currently submit in a quarterly adverse decision and grievances report to include whether AI, algorithm, or other software tool was used in making an adverse decision. So there was a set of amendments that were sent around. There are 3 amendments. These 3 amendments sort of need to be separated out a little bit. The first and third amendments were offered by the carriers or were suggested by the carriers. The first amendment requires a carrier to report when AI made an adverse decision rather than when it was used in making the decision. And the amendment, do you just want to do one at a time, Chair?
Yeah.
So
Yeah,
start with that one. Okay.
Let's try that one first. Okay. Let me ask first, this was Delegate Hill's bill. Delegate Hill, do you want to speak to the bill?
Yes, thank you, Madam Chair. Essentially, we're very concerned about the use of machine learning systems and trying to make sure that they're done in a responsible manner. And we've seen an increase in denials of service that are attributable or seem to be deeply connected to these AI systems that are being used. And so as a first way of addressing it, we wanted to gather the data on how often the systems are being used, where they're being implemented, how many denials are coming up. And then once we understand that, then I think we'll be in better position with the Insurance Administration to come up with the guardrails for how we want to, allow and not allow such systems to be used, prioritizing patient health and outcomes, not simply as many of the users do, the bottom line and how much money can be saved. So this is just a first step to try and get that information.
Thank you, Delegate. Delegate, are you comfortable with the First Amendment? Do you have the First Amendment?
I have no amendments.
Okay, so the First Amendment, if you've got the bill in front of you,
Mhm.
you look at page 2, line 19. And
Mhm.
as what's being recommended is strike was used in making and substitute the word made. So if
Or
you want
other software tool made.
to, I don't
So,
think
and whether an artificial intelligence algorithm or other software tool was made?
this was that the decision was being made by the algorithm. Let me pull up the bill.
Well, I think the problem is that as is practiced now, the algorithmic system can be used, and then a human being comes by and says, "Yep, I agree." Any step along the way, it doesn't have to be the final step for the algorithmic system to be a problem. If it's being used as part of the decision-making process, we need to know that. So it's sort of like a speed camera thing, right? The fact that a police officer signs off doesn't mean that, as we found out, that the systems are working the way they should. So I think that that amendment will make it difficult. If I'm reading it, and again, I don't have it in front of me, but from what I just read, it would mean that the algorithmic system would have had to been the one making the decision, and that's not how we're using them. They're informing the decisions. They're being used in other ways, and the person is just signing off and saying, "Yep, that's the system, and it's consistent with the system." The system's the problem.
Okay, I'm gonna go. I've got a couple of hands here. Let's hear from them, and we will continue the discussion on here. Let's go with Dana Kaufman first.
Thank you, Chair Cullison. In looking at the amendment, I think I'm a bit confused because it says that it made the decision, but if you look at page 4 or 5, lines 21 through 23, it says that the artificial intelligence can't replace the role of the healthcare provider in the termination process under 1510B07, which says that the physician has to be making the decision. So there seems to be an inconsistency with using the term made because it's an affirmative decision as opposed to a tool that's used in getting to that final decision.
Okay. All right. Thank you. I'm going to go to Delegate Taveras and then come back to Matt Celentano. Delegate Taveras?
Ice buddy. I understand the spirit of the legislation, but I also think that this is a bill that is not standalone. I think that it comes in a package with HB 995 in the sense that you want to start looking at, is there a tendency now that we're using AI to overwhelmingly provide denials in a certain medical situation where there's a medical necessity? And I think that we just want to start looking at it at at the outcomes of these decisions in a group.
Okay.
And I don't think that we can do that without that study, because as of right now, all we know are just, oh, we are denying 130 million per year.
So Delegate, just to make sure, this part is telling us how many decisions were being made and how they were made. So, which is what you're looking for. Okay, I'm
Yes.
going to go to Matt Celentano and then to Jamie Sexton.
Thank you, Madam Chair. So I want to back up just for a second to talk about the sort of universe of AI in general, and to sort of reinforce and hopefully make some of the folks on this call feel a little more comfortable. AI is just a tool, right? It's a tool that carriers use. And any of those tools that a carrier use is under the regulatory umbrella of the Maryland Insurance Administration. The MIA also issued a bulletin last April that was developed by the National Association of Insurance Commissioners, a national model to regulate the sort of usage and reporting and transparency of AI systems. All the carriers are operating underneath that bulletin, which has now been adopted by, and my friends at the MIA can reinforce, but over, I think, 15 states so far have already adopted this bulletin to govern AI usage in health insurance. But once again, AI is just a tool. The world is becoming more and more automated, and there has been algorithmic sort of approaches to a lot of these the technicalities for a very long time. I want to make it very, very, very clear. No carrier, zero, zilch, no carrier uses AI to deny any care. All right, I will say it 100,000 times if I have to before April 7th, but zero carriers use AI to deny care. It is always a human. What we are concerned about with, and I'll let my colleague from United, Aaron Appel, speak to this particular amendment, though, is that there are lots of things that are being used in the affirmative space with AI that we do not want to see limited. And that includes paying claims much, much faster. That includes flagging high-risk patients that might have been discharged from hospitals, but because of their complex medical situation, AI is flagging them for follow-up to do care coordination. And there are endless examples of this that we do not want to limit with some of these bills that are trying to do best practices and make sure that carriers have had the protections codified, but could be sweeping in the things that AI is doing really, really well. And because of those automated systems that are sort of taking over the world in lots of ways, we are trying to make healthcare more efficient. We want payments to go out faster. We want care coordination of electronic medical records to happen faster. We want all those things to happen as quickly as possible, because in turn, those efficiencies turn into premium savings for consumers. So automation on its, at the overarching level is not a bad thing. And we want to harness the great portions of AI to be able to make healthcare more efficient, because you all know affordability is accessibility. And that's got to be one of the overarching themes that we try to attain. So thank you for letting me chime in. I appreciate it. Thank you.
I'm going to go with Jamie Sexton first, and then we'll go to Aaron Apple.
Thank you, Madam Chair. We are strongly opposed to this amendment. I don't know that I can say anything beyond what Delegate Hill already suggested as far as the reasons that we're opposed. Software can't be used to make an adverse decision under current law. The issue is how it's coming into play in the lead up to that decision. And so we're not talking about generating a summary, we're talking about the other work previous to it. And so we're opposed to this amendment as it currently stands and prefer the wording prior to.
Just to be clear, so you are saying don't amendment, you continue using the language was used in making the adverse decisions.
Yes, ma'am, that's correct.
Okay, Aaron?
Thanks, Madam Chair. Aaron Appel with United Health Group. I think the goal for the amendments was just to clarify that let me back up for a moment. But I'm going to be very clear when I say United, we never, ever have AI make an adverse decision. It's always done by a human clinician. And so we've been very clear about that from the start. And I'm happy to share any of our external facing materials that state just that. But I think our concern is that we, as Matt suggested, there are a significant number of benefits to through utilization of this technology and speeding up claims and assisting members in a multitude of ways. And what we're concerned about is limiting that. And I think the goal of the amendments was just to make the intent of the law or intent of the bill more clear. And we'd be happy to work with the sponsor to see if we can possibly tighten up the wording just to make sure that the benefits of AI in the healthcare space aren't limited, inadvertently through any passage of legislation.
Thank you, Aaron. Delegate Hill?
Thank you, Madam Chair. I appreciate what everyone has said. The language in this section of the bill was chosen very deliberately, number one. Number two, this is a information gathering bill. Mm-hmm. So the adverse outcomes or effects or undoing good work that both Matt and Aaron have spoken to has nothing to do with this bill. We're getting the information. If out of this bill, MIA and this committee, I as a sponsor, whatever, decide that there are some ground rules that we want to set up, that's the time to talk about whether or not there are good outcomes that were inadvertently affect them. Not this bill. This is just to gather information. I really ask the subcommittee to reject this amendment. Thank you.
Delegate Bandari. Thank you. Thank you, Delegate Hill. Delegate Bandari.
Thank you, Madam Chair. On page 5, lines 18 and 19, I see the last phrase, medical necessity. So I think there is not clear definition of medical necessity. There could be a potential problem. Insurer or AI developers could interpret this medical necessity differently, leading to inconsistent application of the law. So I would like to see if you could define medical necessity.
Delegate Bandari, that's a separate amendment. We're going to talk about that.
Okay.
We're just doing number 1 right now, the first
Gotcha.
amendment.
Okay.
So we'll come back to you. Delegate Taveras.
I'm not sure if I'm understanding the argument. I mean, we could say, if we don't want to say made, we could say contributed to making the decision. But other than that, I would just say, how are we accounting for the potential of implicit bias? Of allowing to trust a computer too much.
Okay, so I think what is happening is in the algorithms, they are attempting to address it, but I'm wondering if maybe Ernest Williams from the OAG's office might have a response to that, as well as whatever else she was going to contribute.
My contribution was only to, I think I'm supposed was to agree with the MIA and say that we oppose for the same reasons as the MIA. I think when it comes to implicit bias, I think that's why Delegate Hill has introduced this bill, is to get the information and then to decide further if there needs to be more detailed information to just, to understand what is happening in the process versus just the final decision. I think it's easy to say this is the final decision, but understanding what's actually happening and who it's happening to is probably going to be the key part that comes out of this. Hopefully, if the bill passes with the amendments that Delegate Hill is proposing.
Okay, so you don't want made, you want to keep it was used in making.
That's right. That's right.
Okay. That's fine to me.
Okay. Can I have a motion on this first amendment? Do I have someone who's ready to make a motion?
Move favorable on the amendment.
You're moving, Delegate Taveras? I didn't hear you just say that. What you just spoke to.
No, sorry. Sorry, rejecting the First Amendment.
Is there a second?
Second.
There's a motion and a second on this amendment. Further discussion on this amendment. I just would contribute that, as Delegate Hill said, this bill is about gathering information. Ultimately, I think what that section of the law is going to do is there's going to be a report that essentially on every adverse decision it was used in making. So, and we'll have that information, and that how the fact that it is being used to contribute, as Matt really eloquently said, to facilitating the work. But we need to continue gathering that information. So with that, I'm going to ask for a vote on the amendment.
Can I just ask a quick question? Did Delegate Taveras move the amendment or move to reject the amendment? Because
she moved to reject the amendment.
Okay, so we're
so the question is, those in favor, those opposed to the amendment, please raise your hands or say aye. Those opposed to the amendment. Okay.
You mean in favor of the unfavorable?
I mean, favor of the unfavorable. Yes. Thank you, Delegate Kaiser. Those in favor of the unfavorable, please raise your hands. or say aye. Okay, those opposed to the unfavorable, raise your hands. Okay, so we are not accepting amendment number 1. Let's go to amendment number 2. Lisa, where to tell us about amendment number 2?
Okay, so amendment number 2 is from the Maryland Insurance Administration, and it clarifies that the use of AI may not result in unfair discrimination.
And that kind of gets to the question that Delegate Taveras was asking. Discussion on this amendment. I'm going to go to MIA, or well, let's go to Delegate Hill first.
Thank you. And Madam Chair, again, I don't have these amendments, so if when Lisa tells what the amendment does, if you can tell me what page and what it says, I would be most appreciative.
Okay, so if you go to page 4 of the bill, look in line 25. What is being recommended here is to add the word unfair before the word discrimination.
Very
and
good.
strike the rest of the line.
Very good, because we can discriminate fairly and unfairly. Very good. All right, thank you. No opposition from me.
Okay. Any other discussion on that amendment? Delegate Shalega.
Isn't that already illegal?
Lisa,
To unfairly discriminate. Don't we have that in many, many, many laws?
I think this is just trying to clarify that the use of AI cannot be used
that's what
for
I mean,
unfair discrimination.
I mean, okay, it seems very redundant, and you know, we already say that if it unfairly discriminated, the trial attorneys would line up at the door.
And this law will give them the opportunity to do that. Okay. So do I have a motion on amendment number 2?
So moved.
Do I have a second?
Second.
Any further discussion on amendment number 2? Seeing none, those in favor of amendment number 2, please raise your hand and say aye.
Aye.
Aye. Any opposition to amendment number 2? Raise your virtual hand so I can see. Seeing none, it's unanimous for amendment number 2. Let's go to amendment number 3. And Delegate Hill, amendment number 3 is would be on page 5. And it's line 19. And after the word or, you would add adversely. And then after the word services, add based in whole or in part on medical necessity. So Delegate Hildy, so it would say an artificial intelligence algorithm or other software tool may not deny, delay, or adversely modify healthcare services based in whole or in part on medical necessity.
Okay, and is that from the MIA as well?
No, that one is it was suggested by the carriers.
Okay, so Matt, do you want to, yes, you do want to speak to it. So Matt?
I do. Madam Chair, thank you. Delegate Hill, this was the amendment that we offered at the hearing in our letter, and this would basically conform the bill to the model bill where this bill came from. This is added, I don't know if it was oversight or a misstep, but this conforms it to the California language that passed last year.
So let me see if I understand it again. So it says, it would say an artificial intelligence algorithm or other software tool may not deny, delay, or adversely modify healthcare services in part or in whole.
Mm-hmm.
Based on medical necessity.
Based on medical necessity.
I'm not understanding it, Matt. I'm not understanding. What is the meaning behind that in part or whole means at all? I don't understand what that's trying to do.
Well, I think Delegate Hill, just like every other healthcare service, where we wanted to be clear that it's based on medical necessity, and also to add deny, delay, or adversely modify health. If we're throwing around adversely in the code all over the place, so it feels like a good addition here to align with all the other approaches that we've had in this bill, in House Bill 848, House Bill 995, and the other bills that I'm surely we will be talking about on adverse decisions this session.
Okay, so Madam Chair, again, since I'm just seeing this and I'm always looking for the hidden meanings, and have to read the paragraph above to understand the context and the impacts of that, I would like to hear from the Office of the Attorney General and the MIA before I chime in on how I feel about that amendment. I think I think the language was carefully chosen, and any difference between this and the California language, I think was a deliberate decision, but I'm interested again in hearing from those other two entities.
Okay, thank you, Delegate Hill. I'm gonna go to Delegate Bandari first, and then we'll go to the MIA and Riley.
Thank you, Madam Chair. Now I'm on the right amendment. Matt, on your amendment, so you said this medical necessity. So, like, don't you think that is very vague? Can we use some sort of a Delegate Hill standardized framework, like such as Maryland Insurance Code or American Medical Association, AMA definition? If not, there could be a potential problem. The insurer or AI developer could interpret medical necessity differently, leading to inconsistent application of the law.
Delegate Bandari, I actually think that it's the opposite of vague. It's actually a legal term of art. Medical necessity is in regulation in the Maryland Code and already all over the code, and it is the way that carriers decide how to pay for services if it is medically necessary. So I think this is actually makes it clearer in the code, and is, once again, I'm sorry, it's the opposite of vague.
Yeah, I think I would agree, Delegate Bandari. We are working on the prior authorization bill. Medical necessity is on virtually every page of that bill. So, I think that there is it is a term of art, and it is defined in our regulations. I'm going to go to Riley Williams. Riley, want to tell us how MIA feels about this amendment? Oh, Riley, we can't hear you.
Can you hear me now? Is this working?
We can. Yep, now we can.
Great. Thank you. The MIA is also opposed to this amendment because we feel that it significantly narrows the scope of the bill. Again, medical necessity is also already defined under this title of the insurance article. And we feel like the medical necessity is not necessary based on, again, where it sits in the bill, under a subtitle on utilization review based on the medical necessity.
Okay. Thank you, Kimberly Camrata from the OAG's office.
Trying to get there we go. Likewise, echoing Riley, we don't believe the amendment is appropriate. Medical necessity actually within the statute is adverse decision is considered a service that was deemed not medically necessary, appropriate, or efficient. So we would want to make sure we had all of the language in there. But again, we don't think it's necessary because this sits within the utilization review provisions of the law. And so we don't believe it's necessary.
Okay. Thank you. Delegate Hill.
That being said, and thank you, Madam Chair, for allowing me to listen and to take time to read. I would ask that this amendment be rejected and that we stick with the bill in this section as is.
So I need a member of the committee, the subcommittee, to make that.
Or to not move on it at all. If there's no motion on it, then
we can
doesn't move.
Right.
Move to reject the amendment.
Okay, I've got a move to reject. Is there a second?
We don't have to do that. We can just,
we can just not take it. Okay, let's do that then. We will. So we did accept one amendment, amendment number 2. So now And we rejected the other two. Is there any further discussion on this bill?
Move the
Bill
bill.
as amended.
Bill as amended. Any other discussion? Seeing none, those in favor of the bill as amended, please raise your hands and say aye.
Aye.
Any opposition to the bill as amended? Seeing no hands, bill passes unanimously.
Thank you, Madam Chair, and thank you, subcommittee members and everyone who weighed in. Appreciate it.
Thank you, Delegate Hill, for working on this. And I am looking at, we're going to go to House Bill 848. And that is health insurance, adverse decisions, reporting, and examinations. So I think we talked about this bill last week, but as a result of some internal discussion since then, Lisa, you want to talk about the bill a bit and where we're finding ourselves with needing to amend it?
Sure. So just to refresh your memories, this is the bill that expands the required contents of the quarterly appeals and grievances report. If the number of adverse decisions issued by a carrier for a type of service has grown by 10% or more in the immediately preceding calendar year, or 25% or more in the immediately preceding 3 years, the carrier must include a description of any changes in medical management contributing to the rise in adverse decisions for the type of service. So this bill deals with adverse decisions. Since we discussed it last week, there was raised a concern in a bill we passed actually last year, having to do with prior authorization and adverse decisions. And in that bill, we required that the name be provided for the medical director or employee that was in charge of the appeals and grievances process. So there's been some concern raised about identifying the name of the person responsible. So what the new amendment that you have, and it's incorporated into the old amendments you have, but what it does is that it would, instead of requiring the name, it would require identifying information. Now, since I sent out the amendments, this is another one that has been agreed to and instead of putting identifying information in code, there has been an agreement to put unique identifier for the medical director or person in charge of appeals and grievances.
Okay, questions on the amendments,
Move the
that
amendment.
particular amendment? Okay, now I have to ask Lisa, did we pass the other amendments last week, or we did?
Yes, we passed everything except for that one.
Okay, all right, that's what
But you can vote on all of it again together.
Right, okay. Delegate Kipke, you okay moving all the amendments?
Let's move them.
Okay, let's move them. Do I have a second on all the amendments? I got a second. Any discussion on the bill? Seeing none.
Move the bill with amendments.
Thank you. I've got a motion and a second. Those who in favor of the bill as amended, please raise your hand. Say aye. Aye. Anyone opposed to the bill as amended? Seeing none, bill as amended passes unanimously. Thank you all very much. First of all, for working together to try to figure out how to make the bills better. And secondly, for the good discussion that we had today. I appreciate everyone's work on this. We have 25 minutes before bill hearings at 1 o'clock. And so we'll see some of you in the committee room. Thank you all very much.